Right. Okay. So, so now we finished cardiovascular medicine and respiratory medicine. Now we move on to hepatology, gastroenterology. අර ප්‍රශ්න ටික මම දැම්මා gastro ඒවා ටික හම්බුණාද?
ඔව් සර් ඒ ටික තිබ්බා.
හරි. Okay. Right. Okay. Hari. Now, the first question is on jaundice, right? So, as a final year medical student, I'm sure you know that jaundice is the main hepatological manifestation. So, hepatic disease presents with jaundice, right? And during your professorial appointment, so every single group, I have done a detailed long case discussion on jaundice, right? And obviously, we're just going to use some of the knowledge acquired during that appointment to answer these MCQs. Simple. Right. Now remember, we talked about sort of this sort of thing, neither, in the prof appointments. I told you that jaundice can be classified into 3 big groups, right? So you have the prehepatic jaundice, which is in adults is almost always due to hemolytic anemia, and also rarely some disorders of uptake and conjugation like Gilbert's syndrome, right? And then we have the hepatic jaundice, which can actually be divided into 2 other sort of 2 groups as well, based on their clinical and biochemical profile into the hepatocellular pattern of hepatic jaundice or the cholestatic pattern of hepatic jaundice, right? And then finally, you have the obstructive or post-hepatic jaundice as well, right? So, so from what we discussed, this is your classification of jaundice into these groups, right? And in your professorial appointment in the long case, we discussed the clinical manifestations and the laboratory features of each of these groups in detail. All right. So the first question is on cholestatic jaundice. Cholestatic jaundice. Now here the word cholestatic jaundice can either refer to an obstruction or a post-hepatic disorder, or within the liver, an intrahepatic cholestatic disorder, right? So when we use the word cholestatic jaundice, that broadly refers to either a post-hepatic or obstructive disorder or a liver problem with cholestasis, right? Okay, first one. Point right, good. So the first question is known to occur in patients with viral hepatitis. Now this we talked about during the appointment. Viral hepatitis can present with a predominantly hepatocellular pattern, right, where there is a lot of hepatocyte necrosis and death, but it can also present with a cholestatic pattern. For MCQ purposes, please remember that all your viral hepatitis can sometimes start off with a sort of a hepatocellular injury and then have a delayed cholestatic phase later on in the illness. So it is in the natural history of hepatitis viral infection. You can initially get a sort of a hepatocellular phase and also a prolonged cholestatic phase, right? So cholestatic jaundice is known to occur in patients with viral hepatitis is true, right? Right. Now what happens in cholestatic jaundice is mechanistically or mechanism that the bile is being conjugated without a problem. There is no problem at all. The bile is being beautifully conjugated, right? But the problem is that this conjugated bile is stuck inside the liver, right? It cannot flow through the liver. The small bile canaliculi, small bile ducts, it can't flow through those ducts and enter the big sort of hepatic and biliary ducts. So it is essentially what happens is, in coli, especially when it's inside the liver, is that the bile is stuck, right? It's being conjugated, but it is stagnant. So what type of hyperbilirubinemia do you get? It is a direct hyperbilirubinemia. It is a conjugated fraction that of bilirubin that is elevated. So this is a direct hyperbilirubinemia. Indirect hyperbilirubinemia you get in prehepatic jaundice, right? So patients with hemolytic anemia or patients with something like Gilbert's syndrome, right? These people present with an indirect hyperbilirubinemia, right? But patients with cholestasis, when there is stagnant bile, right, or bile is stuck, there you get a direct hyperbilirubinemia because there's no problem in the conjugation of the bilirubin. Hari. So, eka වැරදි. Now, again, if you take your memory back to your prof appointment, I told you that in these cholestasis disorders, right, if you take their liver function tests, right, look at their liver function tests, you will clearly see that it is the ALP and the gamma GT, which are predominantly biliary enzymes that are elevated, right? So it is the ALP and the gamma GT that is elevated. The transaminases, AST, ALT can go up a little bit, right? But it is predominantly the ALP gamma GT that goes up. There is another enzyme also called 5-nucleotidase, right? That can also go up in these cholestatic disorders. So ALP you know, gamma GT you know, and nucleotidase you know. Right? That is a very important point. Right. So what you see is a disproportionate rise in the alkaline phosphatase and the gamma GT compared to the transaminases. Right? Transaminases can go up a little bit, but it is the majority. What you see is a predominant rise in the alkaline phosphatase, gamma GT, or 5-nucleotidase. Right. Another point to remember is patients who take alcohol can have an isolated rise in their gamma GT. So be careful, right? So patients who take alcohol have an isolated rise in their gamma GT because it's sort of an inducible enzyme. When they take alcohol, the gamma GT levels can go up. So that is just an isolated rise in the gamma GT. So don't mix it up with anything else, right? So patients who take alcohol can have an isolated rise in their gamma GT. Right, good. Now, in a patient with cholestatic jaundice, either the bile is stuck within the liver or there's a problem of obstruction. What happens is they cannot form urobilinogen because there is nothing going into the gut, right? So if you remember the bilirubin metabolic pathway, you will know that urobilinogen is formed once the conjugated bilirubin enters the gut, right? So once the conjugated bilirubin enters the gut, they form urobilinogen. So if there is a cholestatic disorder, obstruction or bile not moving, then they cannot form urobilinogen. So if you check their urinary urobilinogen, that will be absent, right? But another related point is that if you check their bilirubin diglucuronide levels or conjugated bilirubin levels in the urine, that will be high, right? Because what happens is, because of this obstruction, you get the very water-soluble conjugated bilirubin regurgitating into the bloodstream. So the very water-soluble conjugated bilirubin regurgitates into the bloodstream and is excreted in the urine. But that is bilirubin diglucuronide or conjugated bilirubin. It is not urinary urobilinogen, right? So these are two things that you measure in the urine. You can measure the urobilinogen, which is absent, but if you measure the urine conjugated bilirubin or the bilirubin diglucuronide levels, right, that will be elevated. And that is because this conjugated bilirubin that is forming in the liver, there is no place for it to go, it regurgitates into the bloodstream. Okay. Right. Finally, you can have a deranged PT-INR because remember, bile is important in absorbing vitamin K or fat-soluble vitamins, right? So you can have a deranged PT-INR. Okay, that is possible. Yeah. So two questions. Urobilinogen is absent or very significantly reduced. You can't detect it essentially. Dipstick method එකක් තමයි ඔකට පාවිච්චි කරන්නේ දැන්. ඒක detect වෙන්නේ නැහැ. Right? So urinary bile means urine bile කියන්නේ, that is the conjugated bilirubin, right? So when you measure urine bile, you are measuring bilirubin diglucuronide or conjugated bilirubin. You have to specifically request for urinary urobilinogen if you want to check the urobilinogen. right? So when you request urine bile, you're checking the conjugated bilirubin. If you want to check the urobilinogen, you have to specifically request for urinary urobilinogen. Right. Any other questions from this? So this is just a basic clinical question from the various types of jaundice and the various categories of jaundice: pre-hepatic, hepatic, and post-hepatic.
Sir,
Okay, yeah.
sir, what are these urinary bile salts?
Oh, a urinary bile salt can take a urine bile salt. All of these are conjugated bilirubin. Yeah.
Okay, thank you, sir.
Yeah.
Sir,
Mm-hmm.
the fraction of direct bilirubin or total bilirubin to say obstructive jaundice? Is it 2/3?
So obstructive if they to say it's a predominantly conjugated hyperbilirubinemia, there should be at least 20% of the total bilirubin. You should have at least 20% of the conjugated fraction to say. Yeah.
Thank you.
Okay. Perfect. Right. So this is what we discussed just now. So may table this is essentially important for long cases also. So I'm not going to go through this. You should know by now. Clinical study අපි මේක කරා. Right. Okay. Now question number 2 is on cirrhosis. Now just to remind you, because in the question that you can get one statement on sort of the pathogenesis of any disorder. Right? So the next few questions are based on cirrhosis. Right. Now, this picture sort of is a nice summary of what exactly happens in cirrhosis. So what happens is, when the normal liver receives an insult, right? And remember, this insult that the liver receives is over a long period of time. It's not a single one-off challenge. There are repeated insults to the liver cells, right? So when this happens, there is a cell called the stellate cell, right? So the stellate cell lies between so these are the hepatocytes, right? And the hepatic sinusoids, which are the blood vessels that run around the hepatocytes. So the hepatic stellate cell lies in it's called a niche, right? The word we use, English word, is a niche between the hepatocytes, the layer of hepatocytes, and this hepatic sinusoid. So it's a long cell with long arms like processes, right? When the liver receives a lot of insults, say alcohol maybe, infections maybe, right? Medication, this activates this hepatic stellate cell and also the Kupffer cell, which are actually a subset of macrophages lining the tissue, right? And remember, the macrophage function is also always to sort of eat up debris and clean things up, right? So what happens is, because of these repeated insults, your hepatic stellate cell gets activated and starts laying down collagen, right? So this leads to fibrosis. So whatever liver insult you get, which leads to cirrhosis, ultimately, pathophysiologically, you're causing an activation of your stellate cell. And the stellate cell is now laying down collagen, right? So that's what happens. Right. So that's a little bit of an introduction to what the pathogenesis is. So statement 2 is correct. That is the pathogenesis. Right. Now, when it comes to etiology, yeah. So Hiran, what I was saying is, what happens? Repeated insults to the liver activates the stellate cell, right, and starts laying down collagen. There are Kupffer cells also lying around, and they sort of gather up the debris, clean up the sort of parts of the liver cells. Right? So that's what those cells do, right? But it's a hepatic stellate cell that starts laying down the collagen. Now, battery ball. Okay, right. sorry. Sorry. Screen එකයි පේනව නේද?
Yes, sir.
Hi. Okay. Right. Now the statement number 1 is based on the etiology, right? So again, this is something that we have discussed during the professorial appointments. And I told you that the commonest etiology of cirrhosis is alcohol, right? Of course, a very close second now is the non-alcoholic fatty liver disease or metabolic liver disease syndromes that you see, and that's sort of catching up very fast to alcohol-related liver disease, right? Of course, there are other etiologies which we have discussed as well. Now, remember that cirrhosis is a histopathological definition, right? Remember that. So what happens is there is death of hepatocytes, right? And then there is sort of fibrous tissue replacement causing a distorted hepatic architecture. And in regions, you see regenerating nodules, right? And which is shown in this picture, which is shown in this picture there. Now, remember the regenerating nodules can be of varying sizes pathologically, right? So they can be of varying sizes. And some etiologies cause macronodular cirrhosis. Some etiologies cause micronodular cirrhosis, right? Most of your infection-related autoimmune, that sort of hepatitis causes a macronodular cirrhosis, whereas alcohol causes micronodular cirrhosis. So it's based on the nodule size, right? These regenerating nodules, how big they are, you can have either macronodular cirrhosis or micronodular cirrhosis, right? Okay. So make a hurry. Pathological macronodular cirrhosis and micronodular cirrhosis you get in alcohol, right? And then etiology-wise, of course, you know all the etiologies here. So etiology, I said alcohol is very common, right? And non-alcoholic fatty liver disease is a leading etiology in most parts of the world as well. And then you get these rare things like hepatitis B, C, D, rare metabolic syndromes, like hemochromatosis, for example, autoimmune hepatitis, right? That can lead to cirrhosis, and also there are biliary tract diseases, right? Most of them are autoimmune biliary tract diseases that gives rise to cirrhosis, right? Okay, so going back then, cirrhosis does not occur in hepatitis E infection. It is hepatitis B, C, and D. And if you remember your microbiology, virology, this hepatitis D cannot exist without B. So they always go together. Hepatitis B and D, they always go together. Hepatitis A and E causes an acute hepatitis, but does not cause cirrhosis. So the first one is wrong. Right. Now, looking at the diagnosis of cirrhosis, right? Ideally, because cirrhosis is a histopathological definition, ideally you want to do a biopsy, right? And have a look at the features on the biopsy. But this is not always possible. So again, when we did our long case, I told you that we use adjunctive or supporting investigations to make the cirrhosis diagnosis. And the most useful investigation is an ultrasound scan of the abdomen, right? Where you can see this coarse hepatic architecture, where you can see features of portal hypertension very clearly, right? So the ultrasound scan is a gold standard, become a gold standard as a supporting investigation of choice. Now, if you look at their liver function tests, right? Again, this is something I told you. Their serum albumin will be low and their PT-INR will be high. And this sort of reflects the state of hepatic dysfunction. So, as you know, albumin is synthesized in the liver, right? So, they lose their synthetic function. And also, there are lots of vitamin K dependent clotting factors that are synthesized in the liver. So that affects the PTINR and sometimes the other clotting parameters as well, like the APTT, right? So serum albumin is low and the PTINR is high. The transaminases are usually not significantly elevated, right? That is because the liver cells are sort of exhausted and they're sort of dying and there's fibrous tissue replacement. So don't expect to find transaminases elevated to the thousands, right? They might be slightly above normal and it is AST higher than ALT, right? It's not the other way around, right? So in cirrhosis, what you find is AST higher than ALT, but very minimally increased. It's slightly elevated above the normal range, right? But AST would be slightly higher than ALT. So statement 4 is wrong. It is the other way around, right? And serum albumin is low keneka hari because that is reflective of the synthetic function of the liver. Hari? Right. Any questions about that? Question number 2, any problems there? So if you take specificity of liver enzymes, yes, ALT is a bit more specific because AST you can get from the heart as well. But that the story here is different, right? This is something that we are talking about liver disease and AST, ALT elevation, right? That is a difference. So dekama වැඩි වෙන චුට්ටක්, but AST is higher than ALT, right? In cirrhosis patients. And also several other things as well. Actually, the AST and ALT are produced in 2 types of hepatocytes. There is a differential production in hepatocytes along the portal triad and also the venous system, hepatic vein එක ළඟ තියෙන ඒවායි. But those are not important at your stage now because final exam is mostly clinicals and not all these theory pathological details, right? So in viral hepatitis, hepatitis B, A, B, and viral hepatitis, the ALT is higher. Yeah, that is right, right? So viral hepatitis ALT is higher. Answer all the causes causing cirrhosis also cause chronic hepatitis. Not all of them, right? Not all of them, but specifically things like hepatitis B, C, they can cause a chronic hepatitis. Autoimmune hepatitis causes a chronic hepatitis and cirrhosis, right? But not everything, not everything. Right, so this we talked about. Right, now then if you take the complications of cirrhosis, most of the complications will be related to portal hypertension, right? So as you know, when there is fibrous replacement of the liver, this traps the portal veins as they travel through the liver, right? So when there is fibrous, so remember, imagine inside the liver, there are fibrous bands running all over the place, right? So there are fibrous bands. And these fibrous bands trap the portal veins, right? Or they are constricted. That gives rise to portal hypertension. Now, as a mechanism of dealing with this portal hypertension, with time there is formation of portosystemic anastomosis, right? So this, when the portal pressure is elevated, in order, your body is trying to lower the portal pressure, so the body is forming these portosystemic anastomoses, right? Connections between the portal and the systemic circulation, right? So that is a mechanism from your body to try to lower the portal pressure. But remember, these portosystemic anastomoses cause problems like varices, for example. Right? But that's sort of a mechanism in your body to try to limit or reduce the portal pressure. Right. Sorry. Okay, so portal hypertension, you get this sort of portosystemic anastomosis formation. Right. Another important thing to know, possibly for MCQs, is this. Portal hypertension, right, gives rise to splanchnic vasodilatation as well. right? So that is an important thing. So this portal hypertension that is generated, on one hand, it's sort of trying to create portosystemic anastomosis. On another end, it causes splanchnic vasodilation as a reactionary response, right? What this does is, it pulls all your blood into the splanchnic circulation, right? So all the blood, or because the splanchnic veins are vasodilated, they act as a reservoir, right? So it causes a redistribution of blood into the splanchnic vessels. This causes hypovolemia in the peripheral circulation, right? Especially in the renal vessels, right? So there is hypovolemia, or what we call effective hypovolemia. There is no blood loss, but your blood volume is now redistributing into the splanchnic circulation. This causes hypovolemia. And as you know, when there is hypovolemia, there is activation of the renin-angiotensin-aldosterone system, which gives rise to further fluid and water, salt and water retention, right? So actually, in patients with cirrhosis, they have an overactive renin-angiotensin-aldosterone system, which drives the edema and the ascites, right? Because like in heart failure, this is a harmful system, right? So the main thing is, because of the architectural disturbances and all these sort of bands running all over the place within the liver, the fibrous bands, traps the portal veins, increasing the portal pressure, and gives rise to portosystemic anastomosis as a mechanism to try to limit the portal pressure, right? Also, it causes as a compensate response, splanchnic vasodilatation, right, which sort of redistributes blood into the splanchnic circulation, into the abdominal circulation, right? And this gives rise to a peripheral hypovolemia state, or an effective hypovolemia state in the periphery. And that activates the renin-angiotensin-aldosterone system, right? And this is what drives the edema and the ascites in these patients, right? Okay, now this MCQ is mostly on ascites in patients with cirrhosis, right? So in patients with cirrhosis, they get an ascites, and the ascites is driven by portal hypertension, right? And also this active renin-angiotensin-aldosterone axis. So remember that the ascites that you get in cirrhosis is a low protein ascites, or a transudative type ascites. But we don't use the word transudate here. We measure it by a special index, which is called the serum albumin acetic fluid gradient. So serum albumin minus acetic fluid albumin, right? So that's called the SAG. So because in cirrhosis, your protein content is low in the ascites, the SAG is higher. So more than 1.1 is the cutoff, right? When there is an infection, right? When there is an infection or some sort of malignancy causing ascites, the protein content is high. So the SAG is low, right? So that is an important point to remember. So in cirrhosis, it is portal hypertension. There's low protein inside the ascitic fluid, right? So therefore, what happens is, right? So what happens is, your acetic fluid albumin will be low, right? And this increases your SAG, right? But if there's an infection or a malignancy causing more protein content, right, then your SAG is low, right? So SAG is low. So an elevated SAG in acetic fluid in the diagnosis of spontaneous bacterial peritonitis is varadi. So in spontaneous bacterial peritonitis, there is a high protein-rich acetic fluid. So therefore, the SAG will be low, or more precisely less than 1.1. Right. So that is false. Right. Now, how do you manage ascites? Right. So ascites is managed simple measures of salt restriction. Right. To be absolutely specific, less than 5 to 6 grams of salt per day. That is the guideline. Right. And of course, we use diuretics, right? And we use spironolactone and furosemide commonly in this story, right? And I know that we've discussed this in the long case. We commonly use combinations of spironolactone and furosemide to make it a bit more effective, the action a bit more effective. And in the long case, matak karaganna, I am very refer because I've taught these things before, right? We use a fixed ratio of 100 milligrams of spironolactone to furosemide 40 milligrams. And the reason for this is to maintain the potassium balance. Right? So spironolactone causes the potassium to go up and furosemide causes it to go down. So you're maintaining your potassium balance and you're using a fixed ratio between the two, right? And you can go up to 400 milligrams of spironolactone and 160 milligrams of furosemide. So that is a maximum. Keep on increasing until you get some response. But remember, for the long case also, when you're playing around with diuretics in patients with cirrhosis, make sure that you monitor their renal functions and electrolytes very carefully. And also remember, higher the diuretic doses, they are at a higher risk of developing encephalopathy because they get dehydrated and develop encephalopathy, right? And also they have electrolyte imbalances which trigger encephalopathy. So you are very careful with your diuretics, monitor them carefully, right? Now, of course, if they have gross ascites, right, gross ascites then sometimes the diuretics alone will not work. You need to do a therapeutic paracentesis in these people, right? Therapeutic paracentesis. Now, an important principle is if you are taking more than 5 liters out, you need to replace albumin because it can cause hemodynamic collapse if you remove more fluid. So more than 5 liters removal, you need to replace albumin, right? And there is a dose calculation also. It's 1 liter at 8 grams of albumin that you need to replace, right? So 1 liter at 8 grams of albumin. And depending on the concentration, you can calculate. So wards where we have 10%, 20% albumin. So more than 5 liters, you need to replace albumin, right? Okay. So larger should be accompanied by albumin replacement right. Now, patients who don't respond to you're doing their diuretics, tapping, but still they are getting recurrent refractory ascites. And remember, this is driven by this portal pressure. So in these patients, we can use this TIPS procedure, which I have shown here, which is a transjugular, because you go through the jugular vein to put this in, intrahepatic, it's a portosystemic shunt. So what the body is doing is that it's generating these portosystemic anastomoses to lower the portal pressure. Here we are artificially creating a portosystemic shunt, and that lowers the portal pressure, reducing the ascites. All right. So TIPS procedure can be used in patients who have refractory recurrent ascites. The problem with these portosystemic anastomoses is a difficult thing, right? The portosystemic anastomosis Sri Lankan Amarui, because the problem is that it causes bacterial translocation from the gut directly into the systemic circulation. When these portosystemic anastomoses are active, it causes the bacterial translocation, bacterial ammonia production to go into the brain, and this triggers encephalopathy. So the TIPS procedure is contraindicated if the patient has a history of encephalopathy, right? Because then you're aggravating that ammonia translocation into the brain, right? Okay, so a few questions about albumin replacement. So when you say 8 grams per liter, ideally you have to replace the whole thing that you took out, right? So 6 liters done, you give the whole, say, 48 grams, right? But at least excess of the 5 liters you have to replace. The reason I say that is albumin is very difficult and expensive to get. So if you are remove 6 liters, ideally you replace the whole 6 with albumin, or at least the additional 1 liter from the 5 liters, right? Right. This day 1, day 3 business is a different story. I will tell you what that is in a minute. All right. Right. Now, a common complication, yes, of course, you can't do a TIPS in SBP when the patient has active SBP. You can't do that. It is an outpatient procedure once you treat, right? And again, I would be a bit hesitant to put a TIPS in a patient with SBP because you're playing around with their vessels, ne? So, yeah, you have to make sure that they're absolutely, completely better from it, right? Because it's an invasive procedure. Hari. Okay, now, a common complication of ascites is spontaneous bacterial peritonitis, and it is easily diagnosed. When you do the peritoneal fluid analysis, you get a neutrophil count of more than 250 per cubic millimeter, right? So that is the diagnostic criteria. In a patient with SBP, the treatment of choice is to give them a third generation cephalosporin, right? Ceftriaxone or cefotaxime. That's a drug of choice. And මෙතන තමයි ඔය මේ day 1 day 3 කතන්දරේ එන්නේ. In a patient with SBP, clinical trials have shown that when you give albumin on day 1 and day 3, that improves the outcome, right? Improves the outcome. Probably it prevents hepatorenal syndrome, which I'm not going to go into a lot. But this day 1, day 3 business, if you have a patient with SBP, if you give them albumin on day 1 and day 3, the clinical trials show that the outcome is better and sort of the complications are less, right? That's what it says. Another important MCQ point and obviously clinical point about SBP is, if you have a patient who has had at least one episode of SBP in their life, they need to be on lifelong SBP prophylaxis. So, එක පාරක් හරි SBP හැදිලා තියෙනවා නම්, you need to give them a lifelong prophylactic regime. And the drug of choice is levofloxacin පාවිච්චි කරනවා ගොඩක් වෙලාවට. Levofloxacin පාවිච්චි කරනවා ගොඩක් වෙලාවට. හැමදාම cotrimoxazole is another drug that we use. හරි. Okay. So lifelong antibiotic prophylaxis is true. Okay. Hari. Now, the last MCQ is a bit out of date because, so hepatorenal syndrome, we don't call it type 1, type 2 anymore, right? So now we say there is hepatorenal syndrome with acute kidney injury or hepatorenal syndrome with chronic kidney disease, right? So those are the two types of hepatorenal syndrome, right? If we're going to වැඩිය වද වෙන්න එපා. But for type 1 hepatorenal syndrome, it's commonly associated with gross ascites and it's partly due to reduced perfusion of the kidneys. Volume redistribution එකක් වෙනවා කියලා. So this type 1 hepatorenal syndrome is partly because the kidney perfusion is low. The drug of choice in type 1 hepatorenal syndrome is terlipressin. So we treat it with terlipressin. That is the drug of choice. If terlipressin is not available, you can use a combination of albumin and noradrenaline also, but that is not very effective, right? So the treatment of type 1 hepatorenal is not fluid boluses, it is with terlipressin, right? So අපි type 1 කියලා දැන් වචනේ පාවිච්චි කරන්නේ. It has been replaced by hepatorenal syndrome with මොකද්ද? Hepatorenal syndrome with AKI or hepatorenal syndrome with chronic kidney disease. අනේ antibiotic එක levofloxacin නෙවෙයි norfloxacin, sorry මට ඒක වැරදිලා කියවුවා. SBP prophylactic antibiotic is norfloxacin, not levofloxacin. Right, okay. So ascites, this is all you need to know about ascites and spontaneous bacterial peritonitis. Any questions?
Excuse me, sir. In a patient with SBP and like a significant ascites, can we still go ahead with therapeutic paracentesis?
Yeah, you can do it, but of course, you have to be very careful because if you take a lot of fluid out, they can get encephalopathic. So you have to be very careful. All these things go together. So you have to be very careful. So if they have encephalopathy, you have to be very careful with diuretics. You have to be very careful with therapeutic aspirations. We don't do anything until they recover from their encephalopathy, right? SBP also, you should try to avoid these sort of invasive procedures as much as possible until you get the antibiotics in and they are sort of improving or recovering from the condition. Yeah.
Right, sir. Thank you.
Right.
sir, what about the glucose content of the ascitic fluid during the SBP?
Mehemai. So that's not very useful in SBP diagnosis, but sometimes they can have secondary bacterial peritonitis, right? Say you have a gut perforation or something, and they have a massive bacterial load in their ascites. In these people, their glucose content will be very low, right? So sometimes sometimes people come with significant abdominal sepsis and they have ascites. So spontaneous bacterial peritonitis is just bacterial translocation from the gut into the acidic fluid. But sometimes they have an intestinal perforation, some active infection that is flooding into the acidic fluid. The criteria are slightly different. There are massively elevated white cells and their glucose levels are very low, right? And of course, it's like an empyema, plural empyema. You'll be able to gram stain and culture a whole lot of organisms. Right? That is where you use the glucose. Yeah.
Thank you, sir.
Right. Okay. Good. Right. So the other complication of or consequence of cirrhosis and portal hypertension is hepatic encephalopathy. And this sort of summarizes what happens, right? So the whole problem is this colonic bacteria that produce ammonia, right? That is the problem. Now, usually it is not a problem, and these bacteria are very good for the gut, right? They form the microbiome of the gut. I'm sure you've heard of that term, right? But in patients who have cirrhosis, this ammonia cannot be detoxified in the liver because the liver is not working, right? So the ammonia is usually detoxified in the liver. This process does not happen. And in addition to this, there are portosystemic anastomoses. So the ammonia can bypass the liver, going straight into the systemic circulation and crossing the blood-brain barrier. And this causes an alteration in the neurotransmitter balance, right, in the brain. Especially you get things like glutamate forming and also gamma-aminobutyric acid, GABA, which is an inhibitory neurotransmitter, right? Ochara details now, but there is an alteration of the glutamine-glutamate ratio and the GABA content in the brain, right? So there is altered neurotransmitter activity in the brain. And also you can have cerebral edema and increased intracranial pressure, right? Because ammonia crosses the blood-brain barrier entering the neuronal system, right? So this is what happens. True or false regarding hepatic encephalopathy? Right. Now again, I have told you in your long case classes that in hepatic encephalopathy, probably the earliest clinical manifestation is personality change, right? So they have altered personality. And then with time, they can get altered sleep-wake pattern or reversal of their sleep-wake cycle, right? A useful sign to look for are flaps or asterexis, and they get constructional apraxia. So 5-point, drawing a 5-pointed star. That is, so they are unable to do that, and that is called constructional apraxia. Constructional apraxia. Right, that is true. Now, there are several important precipitants of hepatic encephalopathy. Of them, dehydration and hypokalemia are very important causes, right? These are things that trigger hepatic encephalopathy. So dehydration, hypokalemia. Also, upper GI bleeding, because in upper GI bleeding, they swallow a massive protein load, which gives rise to a whole load of ammonia formation, right? That can give rise to hepatic encephalopathy, so a massive protein load. Also, infection, SBP, or for that matter, infection anywhere can trigger hepatic encephalopathy. So these are some important triggers of hepatic encephalopathy. So precipitated by hypokalemia is true, right? Now, most of the time, hepatic encephalopathy is a clinical diagnosis. Remember, we talked about this. So the fact that they have personality change, reversal of sleep-wake cycles, right? Flaps, constructional apraxia, you can make the diagnosis with a good degree of confidence. But occasionally we need to do investigations, and one of them might be this triphasic slow wave pattern, right? These are all sort of this area also, right? This is called a triphasic slow wave pattern. Or you can measure the serum ammonia. But the serum ammonia levels are not specific for the diagnosis of hepatic encephalopathy, right? They are not specific. Of course, they are sensitive, but they can be, they are not specific, right? Right, so specific net. Triphasic flow waves are a feature in the EEG, but we don't frequently do EEGs unless there's a big question or uncertainty about the diagnosis, right? So somebody does any types of electrolyte imbalance, so it's usually hypokalemia and hyponatremia, right? Hyponatremia. Hansen had a 5-point star candidate, so it's usual high 5-point star like that. Sorry, Hemandin, right? Propranolol. The question Krishna is asking, I'm not very sure. What do you mean? Patient of propranolol, if they get upper GI bleeding, how to assess their bleeding? Not very clear, but we'll come to upper GI bleeding and maybe I'll clarify it there. Right. So main drug of choice is lactulose. So in hepatic encephalopathy, lactulose is the main thing that you use. Right. And I might have told this during appointments. Actually, antibiotics, and of the antibiotics, rifaximin is the drug that we recommend now, is actually used mostly in the setting of recurrent hepatic encephalopathy, right? In the first episode, it's not very effective, right? But it's effective in recurrent hepatic encephalopathy also as a prophylactic measure, as for repeated episodes of encephalopathy. So currently guidelines recommend like rifaximin in recurrent hepatic encephalopathy, right? A patient with hepatic encephalopathy can get generalized seizures, they can get cerebral edema, seizures, so all of these are possible, but if they get seizures, that means it's quite advanced. You're asking why the tachycardia is okay. Right. Okay, so that's about hepatic encephalopathy. There are other drugs which people also give, like Lola, there is not much evidence that it works, right? Lola, right? Lactulose is the drug of choice. Rifaximin, if there are recurrent episodes, so this is the second or third episode, it works. So make a baradi, all patients in recurrences, yeah. So yes, so rifaximin is given in acute management of encephalopathy, but evidence suggests that it's effective. But the effectiveness is if they have had their second or third episode. So if it's a recurrent encephalopathy, that is when it is most effective, right? Not really in the acute first episode, right? First episode. Yes. So all patients, yes, false. Metronidazole is going out of fashion because doesn't have much benefit. We give metronidazole. Hi. So several questions about right. Character features, delirium tremens, you get this very gross tremor. So that is a different picture altogether. And the constructional apraxia also is a feature of encephalopathy. Rifaximin usually is given for 3 to 5 days. So you can treat an acute episode with it, no problem. But it is effective mostly in patients with recurrent encephalopathy. Seizures seizures are common, right? Is uncommon. Triphasic slow wave pattern is not specific for hepatic encephalopathy. No, it is not specific, right? But it is associated, but not specific. Right? Okay. Seizures are very common, but it's not common to get seizures. Right. Okay. Right. Now, then the question number 5 is based on varicose bleeding. Right. Now, red signs. So when you do an endoscopy, you can predict the presence of predict the probability of bleeding. Red signs. But the presence of these signs on endoscopy predict the risk of bleeding in a varix, right? Red signs කියලා ඒවට කියන. So that is true. If somebody develops variceal bleeding, and yes, somebody asked about propranolol, when they're on a beta blocker, you have to go by other parameters to assess hemodynamic stability. නේද? So urine output is a useful thing. Blood pressure can be used, but you can't always go by tachycardia is the first sign of bleeding කියන එක යන්න බෑ if they're on beta blockers. Not only propranolol, any beta blocker or calcium channel blocker. Right. So if they develop variceal bleeding, your first thing is obviously to stabilize their circulation with fluid boluses. And the drug of choice is not octreotide, it is terlipressin. If you don't have octreotide, then you give terlipressin. If you don't have terlipressin, you give octreotide. So this is not the first line therapy. Terlipressin is the first line therapy. Right. Now, do you give FFP in patients with variceal bleeding? Not always. Definitely not unless the INR is significantly deranged, right? So don't just blindly give FFP in patients who have variceal bleeding. Look at the INR and give it, right? Because remember that the clotting is very complicated in patients. The clotting balance between bleeding and thrombosis is very delicate in patients with cirrhosis, right? Because when the liver fails, they lose clotting factors and anti-clotting factors at the same time. So it will be very, very careful when you're giving these clotting products. So I would recommend never give FFP unless their PTINR is grossly deranged, because you don't know what the hell it's going to cause. Some people, even though they are bleeding, they might have a high risk of thrombosis if you give them too much FFP. Right? So you'd be very careful. Right? So look at the INR and then give the FFP. Right. So for somebody who develops upper GI bleeding, terlipressin is the treatment of choice. If you don't have terlipressin, give octreotide. Another very useful treatment modality for these patients is endoscopy. Right. So people who have upper GI bleeding due to variceal bleeding, endoscopy can be diagnostic as well as therapeutic. So you can do banding, ligation of varices as a therapeutic procedure, right? And that's a very effective thing, right? So once you have treated your patient medically or done an endoscopy or whatever it is, you have to think of preventing further episodes of bleeding, right? So now what you're trying to do is you're trying to prevent further episodes of bleeding, right? So how do you prevent further episodes of bleeding, right? The prevention of further episodes, you can do medically by giving them beta blockers, right? Not nitrates. So, ඉස්සර අපි nitrates දුන්නා. නමුත් අපි nitrate දැන් දෙන්නේ නැහැ. හරි? Beta blockers and propranolol, or some people use carvedilol also now. Right? So, propranolol, carvedilol in the long term as secondary prevention. In addition to medication, another good option is endoscopy, right? So endoscopic banding ligation is used as another secondary preventive measure, right? So drugs or endoscopic procedures can be used for secondary prevention to prevent further episodes from happening. Chamat?
Sir, regarding the first line therapy, what about volume depletion before terlipressin?
ඒක මෙහෙම best response එක වගේ තමයි එහෙම එකක් අහන්න පුළුවන්. What is the next best thing to do වගේ ඇහුවොත් එතකොට obviously fluid therapy නේද? But that's not a definitive treatment. You are just stabilizing the patient there, right? So definitive treatment එකට terlipressin තමයි දෙන්න ඕනේ.
Okay, sir.
Right. Okay. And there are several questions about what is better, carvedilol or propranolol. The evidence there is not very clear, but there is a slight sort of tendency to give carvedilol, right? People think it's a bit more effective, but nobody's going to ask that hopefully from you because the evidence is not very clear cut in that area, right? Carvedilol propranolol comparison is not very clear, right? So don't go behind that too much. Right. Now, another thing I told you during the appointment when we were talking about cirrhosis is that research shows that during an episode of variceal bleeding, they are at a high risk of developing SPP, right? So during an episode of variceal bleeding, they have a very, very high risk of developing spontaneous bacterial peritonitis. So we give them IV ceftriaxone as prophylaxis for that, right? And that's for 3 to 5 days of IV ceftriaxone. That improves outcomes as well. So mortality arduino when you give that antibiotic, right? So that is true. Ceftriaxone, even though they don't have SPP, because they have a high risk of developing SPP during that episode, then you have to give them antibiotic prophylaxis with ceftriaxone. All right, so that is about variceal bleeding. So for secondary prevention, or for that matter, any sort of prevention, endoscopic banding ligation is better than medical therapy alone, right? So endoscopic ligation is better than medical therapy alone, right? That is the current evidence. But we used a combination. Combination is even better. So endoscopy banding ligation plus beta blocker combination is the best, right? That is the best.
Excuse me, sir.
Yes.
In a cirrhotic patient, like if he has not had any variceal bleeding, like no hematopoiesis or melena, but if he's been cirrhotic, do you normally go for like upper GI endoscopy to detect if there are varices or if there are any red signs? And if so, do you go for prophylactic banding in that as a primary prevention?
Sorry, I didn't catch the first thing.
Yeah. So if there is a cirrhotic patient, but he does not have any previous episodes of variceal bleeding,
yes.
Do you do a routine endoscopy, like endoscopy, and do you go for prophylactic banding then?
Oh, එතකොට බලලා අපි බලනවා දැන් කොමන වගේද පේන්නේ කියලා බලලා, so you do the endoscopy and look at the degree of extent of varices, and we sometimes band them if we see that they are big, and there are various criteria for that. හරිද? ඒව තියෙනවා අපි band කරනවා.
Right, so you can use that for primary prevention as well.
Primary prevention as well, yes, exactly. Yes.
Thank you.
So Chamatka, beta blockers are acute management because the whole idea of beta blockers is to reduce the portal pressure in the long term. If you give that in the acute stage, what you're going to cause is the blood pressure is going to drop and various other complications. So අපිට acute stage එක කරන්න මේ තියෙන varices ටික වහන්නයි ඕනේ. So terlipressin, what it does is a vasoconstrictor, so it constricts all the varices and closes off all the bleeding points. That's what it does. But in the long term, what you want to do is you want to treat the cause, so you have to lower the portal pressure, and that's why we give the beta blockers. Right. Okay. Now, another important MCQ point is that you should never over-transfuse patients with variceal bleeding, because again, people have found that if you over-transfuse, the bleeding might get worse also. So you have to sort of maintain their hemoglobin around 8 to 9, right? And also remember that point about giving them FFP, it is, FFP in bleeding, you have to make sure that the INR is deranged also before you give it. And that is because of this complicated balance between thrombosis and clotting in patients with cirrhosis. Right. Now, Sandalika has asked a very related question. What happens if somebody is asymptomatic and has a high INR? Right. Again, do not give FFP if they are asymptomatic. No, even if the INR is high, we do not give FFP in asymptomatic patients. Right. And that is again the problem of you don't know what their balance of clotting, anti-clotting is. The only instance where you give FFP in asymptomatic patients for INR correction is if you want to do some invasive procedure, right? So that is the only instance where you give FFP for asymptomatic INR correction, right? If they are undergoing some sort of invasive procedure or surgery or something like that, then you would correct an asymptomatic INR, but never if that, again, there is no other reason why you should give FFP for asymptomatic INR correction, right? Only if they are going for a procedure. That is the only situation. Even in bleeding patients, you have to make sure that the INR is high before giving FFP. Right. Now, the next MCQ is focusing on the spectrum of alcohol-related liver disease. Now, as you know, obviously, alcohol can cause cirrhosis, but there are several intermediary stages before they develop cirrhosis. Right. For example, they can get fatty liver disease, right, where there is fat deposition, right, in the hepatocytes. And also they can get, especially if the patient is taking large amounts of alcohol and binging alcohol, they can get alcoholic hepatitis, right, alcoholic hepatitis. So, Rehani, in upper GI bleeding as a prevention of encephalopathy, lactulose tamai denni, right? Lankawe nan denawa api rifaximin metralizole denawa, but lactulose again is the one and only drug that is useful in that situation, right? Right. Because rifaximin wageva recurrent encephalopathy වලට තමයි the evidence is supportive of, right? Okay. But lactulose, there is no doubt that is the first line drug for encephalopathy in whatever situation, right? Right. So the spectrum of alcohol-related liver disease ranges from just fatty liver, right, where you see central lobular sort of fat deposition, right, to alcoholic hepatitis, right. True or false regarding alcohol-induced liver disease? Females are more susceptible is true, right, because they have slightly different alcohol metabolism, right. Ethanol metabolism is different and they are more susceptible, right. Fat deposition occurs in the periportal hepatocytes. No, sorry, centrilobular. Yeah, sorry, around the central vein here. Those are just pathological stuff which even I can't remember now. Right. Now, a word about alcoholic hepatitis. Right. In alcoholic hepatitis, important thing to remember is that it's just like a hepatitis, very similar to what you'd get even in a viral hepatitis. Right. There are some important biochemical and clinical details about alcoholic hepatitis. Number one, alcoholic hepatitis is strongly related to alcohol bingers. Bingers can rekapata bond nathula hogala bonding, right? So bingers of alcohol. So alcoholic hepatitis occurs in alcohol bingers. Another important clinical thing is the damage is reversible. So alcoholic hepatitis damage is reversible. So even if somebody stops drinking, the liver can still recover. So, alcoholic hepatitis is related to alcohol bingers and is reversible. Right. Another important feature is you never ever get transaminases in the thousands. Almost never. Usually it's around 300 to 500, but never more than that. If you have if you have a patient where you're suspecting alcoholic hepatitis and the transaminases are more than 1000, there is something else going on, right? There is something else going on. Pure alcoholic hepatitis, this is very important, does not cause transaminases of 1000, usually around 300 to 500 maximum, right? A level ekේ තමයි තියෙන්නේ. And it is the AST that is higher than the ALT in alcoholic hepatitis as well, right? Right. So it is AST higher than ALT, but never ever more than 1000. If it is more than 1000, there is something else going on, right? සමහරවිට අපි දකිනවා මෙන්න මෙහෙම ඒවා, right? අරක්කුත් එක paracetamol බීලා මිනිස්සු වෙනවා. එතකොට transaminases more than 1000, right? But pure alcoholic hepatitis itself does not cause transaminases more than 1000, right? Now, alcoholic hepatitis, most patients recover spontaneously and you don't need to do anything much. But there is a important score called Madri's discriminant function. right, or the MDF for short, which used to prognosticate patients with alcoholic hepatitis. හරි ඒක කටපාඩමින් දැනගන්න ඕනේ නම දැනගන්න ඕනේ හැබැයි that is called Madris discriminant function. And if the Madris discriminant function is above a certain score, we use steroids, right? So in acute severe alcoholic hepatitis, we use steroids, and there is a cutoff of this Madris discriminant function. ඒක මෙච්චරට වැඩි නම් steroids have a benefit, and we give steroids. Right? So Madris discriminant function is a guide to therapeutics. It tells you the indication to give steroids as well as it is a prognostic tool as well. Right. So that is about that. Alright. And also in alcoholic hepatitis, right? I told you that it's usually AST more than 80, 300 to 500 maximum, right? Never thousands. If it is thousands, then I told you about this possibility of superadded something else going on, right? They also get a significant leukocytosis. Hari ekat mataka tiyaganna. Leukocytosis එකකුත් එනවා in alcoholic hepatitis. Right? So treatment is you look at this Madris discriminant function and decide on giving steroids or not. That is it. Right. Now, over the last decade or so, the prevalence of NASH has increased dramatically, right? Has increased dramatically. So NASH is a sort of progression along a spectrum, right? And it's related to metabolic disease, right? Metabolic disease means diabetes, hyperlipidemia, වගේ දේවල්, right? Obesity. So what happens in these patients is they get progressive fat accumulation in their liver. So Ashpa is asking what are the cause of AST more than ALT. So AST more than ALT, NA, cirrhosis, alcoholic hepatitis. Then also you can have AST more than ALT in dengue related liver disease as well. Right? Usually viral hepatitis A, B, C, D, E, ALT more than AST. Right. Alcoholic hepatitis is mostly a hepatocellular type jaundice, but it can also cause a cholestatic picture as well. Right. So we're talking about the spectrum of non-alcoholic liver disease. So initially you get fat deposition within the hepatocytes, but then this gets with more progressive fat accumulation, they get a sort of a injury inflammation picture, which is called NASH. And this can progress into cirrhosis. So NASH is so NAFLD කියන්නේ sort of initially you get just a bit of fat deposition, but when it comes to NASH, they get inflammation of the hepatocytes, injury of the hepatocytes, and a little bit of fibrotic tissue. And this gets worse and worse and gives rise to cirrhosis. So that is the spectrum of non-alcoholic liver disease. Okay. And this is some information about the various, the spectrum, right? You get fatty liver initially, and then when it progresses into inflammation, injury, and a little bit of fibrosis, and that progresses into cirrhosis. And remember, patients with this metabolic non-alcoholic fatty liver are also at a higher risk of developing hepatocellular carcinoma. Hepatocellular carcinoma. Right. So NASH, where I told you there is fat deposition and there is inflammation and there is little bit of scarring, requires a liver biopsy for definitive diagnosis. Right? And you are looking for steatosis, it is fat accumulation. You also get hepatocyte ballooning or enlargement of hepatocytes and lobular inflammation in NASH. So ideally, you need a liver biopsy to diagnose it. Right. True or false regarding NASH, right? So NASH wala fat deposition vitak tibila you can't diagnose. I told you, you need to show the fat deposition plus the hepatocyte ballooning and lobular inflammation. So the diagnosis of NASH needs all of these three things. It's not only the fat deposition, it also needs to be the lobular inflammation and also the hepatocyte ballooning to make that diagnosis. Hari? So take a වැරදි. That is not the pathological definition of NASH. I told you that patients with NASH, patients with this metabolic liver problems have a higher risk of developing hepatocellular carcinoma. ඒක හරි. Diagnosis made on ultrasound scan එක වැරදි. මං කිව්වා you have to do a biopsy to be definitive about the diagnosis. So ඒක වැරදි. Right? You need a liver biopsy and you're looking for the changes that I described, the lobular inflammation, hepatocyte ballooning, and the steatosis, which is the fat deposition. Right. Serum ferritin is elevated. කියන එක හරි. මේක අපි දකින්න දෙයක්. Usually in NASH, in all these sort of inflammatory conditions, the serum ferritin can go up. Right? The serum ferritin can go up, and because it is an inflammation related marker, it is an acute phase reactant, right? Of course, in the disease of hemochromatosis, where is iron overload, the serum ferritin will be massively elevated, right? And also the transferrin saturation will be very, very high, right? In patients with hemochromatosis, their transferrin saturation will be very high and their ferritin will be massively elevated, right? But even in patients with NASH and other sort of inflammatory disorders of the liver, you will see a slight elevation in the ferritin purely because the ferritin is actually a marker of inflammation. It is an acute phase reactant. Right. Now, how do we treat patients with NASH? The main modality that everybody agrees on is weight reduction. Right, and weight reduction, right, causes regression of the disorder and can actually cause histological improvement. Yes, that's an important MCQ point. So diet, lifestyle modifications, weight loss, all these things result in a reduction of liver fat, regresses NASH, and also improvement in histology. Right. Yeah. So central lobular fat deposition, yes, in both alcohol and NAFLD you can get. Somebody's asked that question. So very clear. So diet, lifestyle modifications, anything that reduces obesity is involved in histological improvement. Now there are many drugs which have been tried in NASH, but actually none of them have been shown to have a very significant benefit. But if somebody asks you what are the drugs, so a list, metformin has been tried, right? Vitamin E has been tried. Also, some of these newer diabetic drugs like the GLP-1 agonists also people are looking at. So, thama hunda drug ekak nehe, right? But there are lots of drugs in clinical trials like GLP-1 agonists, metformin, vitamin E, or wage drugs people use. Right, but none of them have been shown to have a significant benefit in mortality or outcome. But what is clear, everybody agrees that weight reduction, obesity reduction, that has a clear outcome benefit and a histopathological improvement. Hari, any questions? Now, this is a picture of a fibroscan, which is useful to assess the sort of fibrosis content in the liver in patients with various types of liver disease. It doesn't have to be NASH. Hari? Ek nikan mang etana dala tiyan. Okay, any questions? What is the commonest cause of hepatocellular carcinoma in Sri Lanka? Now that I'm not exactly sure. It should be alcohol, right? It should be alcohol, but please double check on some epidemiology website, Lankawe statistics, but it should be alcohol because viral hepatitis B and C is rare in Sri Lanka as a cause of, because people don't use a lot of intravenous drugs. Now the thing in Australia, hepatitis C causing liver cancer is very common. there is no specific ultrasound finding in hemochromatosis. But if you do an MRI, because MRI can detect iron, it can detect iron in the MRI scan. But again, in hemochromatosis, we don't do it very much because it's a postgraduate thing. You have to do a biopsy, look for iron staining and things like that. Plus the gene mutation, which is for HFE. Yes, Supun. So NASH diagnose karanna you have to exclude other causes, especially alcohol. So මෙතන මේ guideline එකේ මේ diagnostic criteria එක ඔයගොල්ලෝ දැක්කා exclusion of secondary causes and alcoholic liver disease. So ඒකට තියෙනවා daily alcohol consumption should be less than 30 grams for men and 20 grams for women කියලා එකක් තියෙනවා, right? Also, so there are lots of criteria. You have to exclude other causes before you diagnose this. That is important. Yes, it's an important thing. Hari. So question 8 is on viral, I think question 8 and 9 on viral hepatitis. Give me 5 minutes. Yes, Kaini. So height. So how do hemochromatosis ගැන වැඩි කියන්න ගියේ නෑ. But essentially, how you diagnose it causes cirrhosis. You have to show a high ferritin, high transferrin saturation, which is usually above 70%. Because there are lots of iron, we have a high transferrin saturation, usually about 70-80% විතර වගේ transferrin saturation. And then additionally, of course, the biopsy showing a lot of iron, or MRI වලින්ුත් පුළුවන් you can assess the iron content in the MRI as well. Right. Okay. Right. So now question number 8 focuses on some of the epidemiological characteristics of the hepatitis viruses. Right. So just to summarize this, always remember that hepatitis A and E behave very similarly. Right. Hepatitis B, C, D behave similarly. So hepatitis A and E cause acute hepatitis. They don't cause chronic hepatitis and they don't cause cirrhosis. So it's acute hepatitis. And of course, as a complication, they can cause acute liver failure as well. Right. So question number 8, chronicity is a common consequence of hepatitis A viral infection is false. So hepatitis A and E viruses do not cause chronic hepatitis. Hepatitis B, C and D can cause acute hepatitis. Especially hepatitis B can cause a bit of acute hepatitis. C is very unusual, but hepatitis B can get acute hepatitis. So most of the hepatitis B, C, D cause chronic hepatitis, cirrhosis and cancer. And so hepatitis B, C and D can cause cirrhosis, chronic hepatitis and cancer, hepatocellular carcinoma. Right. So hepatitis C infection carries a high risk of hepatocellular carcinoma is true. Chronicity is a common consequence of A. Hepatitis B and D coexist, right? So they always coexist, right? So for hepatitis D to survive, there has to be some either acute or chronic hepatitis B infection. All right. Now, a special thing about hepatitis E is we identify this as an important cause of fulminant hepatitis in pregnancy. So that statement is correct, right? So that is a little special thing about hepatitis E. Now, talking about the treatment options available for chronic hepatitis C, there is therapy now which is available which can almost completely treat it. Almost completely treat karanna puluwan. There is treatment available now. So potentially curative therapy is available for chronic hepatitis C. That's absolutely correct. That is absolutely correct. True. Right. Even for hepatitis B, there are lots of antivirals and interferons which we use to treat them. That's a very complicated area, but you should be aware that hepatitis C can be completely treated. Right. Hepatitis B also, to a certain extent, can be completely treated. So these are important things to know. So just these sort of epidemiological and treatment related things about the hepatitis viruses, this MCQ. Right. Any questions? පොඩ්ඩක් ඉන්න. So hepatitis D in isolation can never cause anything, right? It always has to be with a hepatitis B, right? So ඒක විතරක් දුන්නොත් වැරදි, Ashwa, but remember always they have to go together. Hepatitis D cannot cause independent infections or any problems. It has to always go with hepatitis B. Right. Now, then we come to the very so hepatitis C හරි. ඉමේෂ් එක හරියම පැහැදිලි මොකද්ද අහන්නේ කියලා. Right, now the next MCQ is focusing on the diagnosis of hepatitis B, right? Now this is a very complicated area. I'm just going to teach you about acute hepatitis B diagnosis. Right. Now this is the hepatitis B virus, right, which is a DNA virus, right? And you have several antigens which form the hepatitis B virus, right? So around the molecule you have a surface antigen, right? So around the molecule you have a surface antigen, right? And then within the molecule you have the co-antigen. So these are the two main antigens. So you have a surface antigen around or covering the surface, and you have a co-antigen which is hidden inside the viral molecule. At points in the surface, there is also embedded in the surface antigen another antigen which is called the E antigen, right? So embedded in the surface antigen, you have the we have the E antigen, hepatitis B E antigen කියන එක. Right. Now we can measure these antigens during an acute infection, right? So in order to diagnose an acute infection, you should demonstrate positive hepatitis B surface antigen. That is essential. You have to demonstrate positive hepatitis B surface antigen. And also IgM to hepatitis B co-antigen, IgM. The point there is you cannot measure the co-antigen එක බලන්න බෑ. මොකද ඒක ඇතුළේනේ තියෙන්නේ. You can't directly measure the co-antigen. The best thing you can do is measure the IgM. As you know, IgM is indicative of acute infection. You can measure the IgM for the co-antigen. So in an acute infection, you get positive hepatitis B surface antigen and IgM antibody against the co-antigen. Hari, eka බලන්න. Right. Okay. And then better if you can also measure the hepatitis B viral DNA. So actually, ideally to diagnose acute hepatitis B, you should have three things. The hepatitis B surface antigen positivity, the hepatitis B co-IgM positivity, and the hepatitis B DNA positivity. හරි ඒක viral load එක බලන්න පුළුවන් කෙලින්ම ගාන බලන්න පුළුවන් through PCR. Now the hepatitis E antigen, which is sort of embedded in the surface antigen මෙන්න මේ තැන්වල is actually indicative of infectivity of the virus and the severity of the infection. So it doesn't have to be positive, but if it is positive, that tells you that your patient is more infective and the patient has a likelihood of developing a acute fulminant disease course, right? Or a more aggressive disease course, right? So chronic hepatitis B, now this is acute hepatitis B no diagnose kare api. Chronic hepatitis B is very, very difficult to antibodies it's slightly complicated. I'm not going to go into that now. It is a postgraduate thing, so I'm not going to discuss that. It's very difficult. Hari. So, true or false regarding hepatitis B? Hepatitis B is a DNA virus, not an RNA virus. Right. Progression to chronicity is higher with infection in the neonatal period is obviously true. Virus. So some people get it from their mothers through the placenta or through delivery. If they acquire the virus in the neonatal period, there's a much higher risk of developing chronic and cirrhosis down the line. Hepatitis B positive surface antigen is diagnostic of acute infection diagnose karan acute infection diagnose karan hepatitis B surface antigen එක විතරක් තිබිලා මදි. Because surface antigen can be positive even if people are just carriers of the virus. So in order to diagnose acute infection, you have to show a positive DNA, you have to show a positive surface antigen, and you have to show a positive IgM to the core antibody. Positive hepatitis B E antigen predicts a mild disease course කියන එක වැරදි. It is a more aggressive disease course if it is positive and the patient is more infective. Right. Acute hepatitis B should be treated with antiviral therapy. That's not always true, right? Milder forms of treatment එකක් අවශ්‍ය නැහැ, but there is a way of deciding whether you need to treat it or not. Right? එතකොට ඒක අයින් කරගත්තත් තමයි it's a bit of a difficult thing for undergraduates. You don't treat everybody with acute hepatitis B. Right. So those are the 9 MCQ questions, true false questions. So somebody else, can the surface antigen and antibody coexist? Yes. If the patient is completely cured of the virus, the hepatitis B surface antigen negative, but the antibody will be positive, right? Antibody they can coexist, but somebody completely cured will have a completely zero-converted hepatitis B surface antigen. So that will be low with a high surface antibody level. Right? Okay, hari amaru eva වෙනවා එක එක අමුතු අමුතු වෙනවා when the virus becomes chronic, which is a postgraduate topic which I'm not going to go into at all. Hari. Right. So best response MCQ. So this one, the focus is on a sort of a cholestatic picture, neda. Cholestatic picture එකක් තියෙනවා. And what is the most likely cause here? Yeah, so this is probably drug-induced cholestasis. Yeah, and the unusual thing and thing to remember is you can get delayed manifestations from drug-induced cholestasis. So here it says the coamoxiclav has been taken a month ago, but still you can get symptoms later on as well. Right. So coamoxiclav is well known to cause cholestasis and delayed cholestasis. Right. That is a very clear thing that everybody knows about. Right. Right. This again is on jaundice. So there is a female presenting in the second trimester of pregnancy with jaundice. Now, what is unusual or not important to note here is that the AST is normal, ALT is normal, ALP is normal, gamma GT is normal. It's just the bilirubin that is high. So please make a note of that. And there are no other symptoms. So what is the most likely thing here? So pregnancy, now you start thinking of pregnancy related problems like cholestasis of pregnancy. But there's nothing to suggest that, right? And this is purely a Gilbert syndrome Yes, this is purely a Gilbert syndrome, just the bilirubin high. And if you were to do a fractional bilirubin of direct, indirect, you would find indirect hyperbilirubinemia in this case. Right? What just jaundice, nothing else, no symptoms, all the liver functions are normal, everything is normal. That is Gilbert syndrome, and it will give rise to a indirect hyperbilirubinemia. Right. And this is a table of some of the pregnancy-related liver syndromes, if you want to read. So hepatitis, somebody who has hepatitis B vaccination, right? How do we diagnose acute infection? In the same way, right? Of course, they will have the antibody for the surface antigen, that's what you give in the viral, but they will have high viral DNA. Acute infection, viral DNA will be significantly high, right? So that's the main way of diagnosis. Right, so 60-year-old woman. So if it was cholestasis in pregnancy, the ALP would be very, very high, right? So in cholestasis of pregnancy, you will have a cholestatic picture. Their bilirubin would be high and would be high ALP, high gamma GT, because it's like a cholestasis, right? So here the ALP is normal, gamma GT is normal, everything is normal. It's just the bilirubin that is high. So therefore, it is not cholestasis of pregnancy. If it's cholestasis of pregnancy, they will have jaundice, dark urine, pruritus, very high ALP and gamma GT. Okay. Hi. Okay. මේකට මොකද්ද බලමු. Hari. So this is story of ascites and SPP. Ne? So answer is SPP. There is a high white count. There is a high acidic white cell count. So it's very clear that it's probably SPP. Right. This one, right. So 56-year-old female, diabetes, with a very bad HbA1c, right? 15 units of alcohol weekly, not a lot of alcohol, right? And yeah, obese. So what is the answer here for this one? So here be careful that the patient is drinking alcohol, but it's less than the dangerous limit or whatever you call it, right? So this is possibly NASH because you see the patient has diabetes, the patient is obese, right? And patient is drinking alcohol, but not a lot of alcohol. So the most likely diagnosis is NASH. What is the dangerous limit of alcohol? So you should know that. Yeah. Grams usually it's less than 16 units per week, right? That is a dangerous limit. But here they quantify it in grams also. 30 grams for NASH grams 30 grams for men and 20 grams for women per week. Daily. Weekly it is 15 to 16. Right? Hari. That is it for hepatology. I have covered all the important topics in hepatology. There is a SCQ also, which I'm sure you need to answer. Make a common question even at the SCQ paper. So you need to be able to do that. We have discussed at several points even your appointment about cirrhosis and long cases. So that is fine. Yeah. right. හරි. චමත්කා අහලා තියෙනවා පොඩ්ඩක් ඉන්න. right. පොඩ්ඩක් ප්‍රශ්න ටිකක් තියෙනවා අපි ඒකට උත්තර දෙමුකෝ. Is the liver always palpable in chronic liver disease and early stage? So this I think I might have touched upon in your long cases අතම පොඩ්ඩක් කිව්ව short cases වල එහෙම. Now the liver can be enlarged in the early stages of cirrhosis, right? And chronic hepatitis තියෙනකොට the liver will be palpable. Also, if the patient has macronodular cirrhosis, even in the end stages, you can still palpate the liver. Samahala macronodular cirrhosis tiyanakota, again you can palpate the liver. Even in end stages. Another thing is, if the patient develops a malignancy, hepatocellular carcinoma in a cirrhotic background, still the liver might be enlarged. So these are exceptions to the rule. Appi cirrhosis වල liver එක shrink වෙන්න ඕනේ කියලා, right? But එහෙම හැම වෙලේම වෙන්නේ නැහැ. liver එක enlarge වෙන්න පුළුවන් in various situations. So, early cirrhosis, if they have macronodular cirrhosis, or if they have hepatocellular cancer on the liver in cirrhosis. So serum ferritin වැඩි වෙනවද අහනවා alcoholic liver disease. So serum ferritin can go up in any sort of liver disease when there is inflammation. හැම එකදීම වැඩි වෙන්න පුළුවන්. So it's not specific for hemochromatosis. So yeah. Harishankar Haltino is, do you need to get all of the markers? Yes, ideally yes. So you have to have the hepatitis B viral DNA positive, you have to have the surface antigen and the co-antigen antibody. Yeah, IgM.
Excuse me, sir.
Yeah.
Hello. Sir, then cirrhotic patient කෙනෙක්ගේ අර hepatocellular carcinoma risk එක තියෙන නිසා ඒකේ අර screening විදිහට අපි ultrasound scan එක විතරයිද කරන්නේ නැත්නම් AFP එකත් ඕනේ
You can do both ultrasound scan එකයි alpha fetoprotein එකයි. Right? At least annually you have to do both.
Annually. Yeah? Okay. Thank you.
Dubin-Johnson syndrome, direct hyperbilirubinemia, that's right. The Rotor syndrome, these are all conjugated hyperbilirubinemia syndromes, but not important in adult medicine or pediatric. Kusala, portal vein thrombosis. Yes, Kusala, chronic portal vein thrombosis or hepatic vein thrombosis can also lead to cirrhosis. Yes. Those are all vascular causes of cirrhosis, which are rare. Right. Chamat, I covered the current pull.
Certificate of
හෙට පොඩ්ඩක් අමාරුයි. මොකද මට අද මේ ඔයගොල්ලෝගේ ප්‍රොෆ් ක්ලාස් එක කරගන්න වෙලාවක් තිබුණේ නැහැ. සිකුරාදා ප්‍රොෆ් කෙනෙක් ඔයගොල්ලෝගේ ජූනියර් බැච් එකේ. සිකුරාදා ෂේප්ඩ්.
සිකුරාදා 7:30 නේද සර්? මේ
ඔව් ඒ වගේ වෙලාවට පුළුවන්ද?
මේ වෙලාවනේ ඔව් පුළුවන් සර්. පුළුවන්.
හරි. ඒතර ගැස්ට්‍රෙන්ටරොලොජි එක කරන්න. ඊට පස්සේ එන්ඩොක්‍රයින් කමක් නැහැ නේද?
කමක් නැහැ සර්.
හරි. රයිට්. ඒතර වීකෙන්ඩ් එකේ අපි එන්ඩොක්‍රයින් පටන් ගමු. හරි. හරි. ඕකේ.